Hi, I'd like to welcome everyone to the sixth session of the De-escalation Echo series from the Psychostimulant Grant. We have Molly and Annie from the U going to be talking about how they respond to crisis and their plans and what they do. So I'd like to welcome them and have them introduce themselves.
Thanks. I'm Annie Romano. I'm an education coordinator here at the U. We work with a lot of rural hospitals and affiliate sites within the U healthcare system. And so happy to be here. My background is mainly administrative, but I also worked in education. So I have firsthand experience de-escalating students.
And my name is Molly Webb. I work as a clinical education outreach nurse for the U. Part of my background is I worked in oncology, and then I worked most recently in the emergency department. So I like to consider myself an expert at getting yelled at, and have definitely used a lot of these de-escalation techniques that we're going to talk about in the ED. So excited to be here.
Yeah, so we'll go ahead and get started. Just as a brief introduction, as you see, the content is credited to Chris Snyder, and he worked in the Salt Lake City Police Department for many years, and then worked at the U of U Health as the head of the hospital security team, and then most recently has been promoted to be the chief security officer over the entire University of Utah, and has shared a lot of resources with us. So we're really grateful for that. So obviously the goal of this is to talk about different de-escalation skills and responding to crisis in various settings. We know that you come from various settings. So some of these, if they're really clinical or, a lot about a hospital, that's okay. We'll try to make it applicable to you, and you also can adjust accordingly. If you have any questions, feel free to put them in the chat as we go through the presentation. We don't have any disclosures. So basically, we know that in healthcare, specifically, and generally in the service sector within United States, there's a huge problem of violence and aggression. So here are some of the headlines that we'll see typically that actually got worse during COVID. So unfortunately, many of you and many healthcare workers in general have experienced verbal or physical aggression in the workplace. It's a common problem, and the statistics show us that. So we know that 75% of all workplace assaults in the US are in healthcare settings. So that's a lot. I mean, a healthcare setting often is stressful for many people. They could be there as a visitor for a loved one who is suffering, or they could be there themselves, not in their best mental or physical state. So because of the stress of the setting, I think it accentuates some behaviors that may not be shown in other environments. And then 47% of physicians have said that they were physically assaulted at work, and 2 nurses are assaulted every hour, according to a 2022 study. So we all know that this is a problem, and it's a common problem. And so a lot of people will just say, oh, it's part of your job. Like, that's just kind of part of what you signed up for. But we want to emphasize that that is not the case. Everyone deserves to work in a safe, positive work environment. And if we normalize that sort of behavior, you can normalize the idea of working in a hostile work environment. So it's important to think of that with yourself as well as your coworkers and colleagues, not to brush aside or normalize, oh, that's just kind of what happens here. And take these incidences seriously, not only for your mental health, but also in reporting, so that the organization itself can make changes as necessary.
All right, so today we are going to cover a couple different objectives. So obviously we want to be able to identify crisis behaviors. After talking to Carissa a little bit before starting this meeting, we know that you guys have kind of gone over identifying these crisis behaviors already. So this might be a little bit of a review for you, but just to tie it all in. We also want to be able to recognize and respond to an escalating situation. So knowing we've identified it and what we're going to do next. We're going to touch on situational awareness as well as verbal interventions that we might do for these escalating situations. And then we want to be able to identify resources that you might have at your disposal. So some of these resources you might not be aware of, we want you to encourage kind of figuring out what your institution offers to protect you in a crisis situation, or what kind of reporting resources, like Annie talked about, the process to go through after a crisis situation. All right, so we are going to start off with a short video clip. So this is just a little screen grab from a hospital in, I want to say Russia, but we've never actually fact checked that. But anyway, this video runs for about a minute long. There is no audio. Fair warning, it is graphic. Before we even start, just take a minute to kind of observe what's going on, the interaction between these two individuals. Take note, maybe keep in mind what they are doing, what could be done differently, and we'll discuss a little bit after the video runs. I hate watching it every time. Annie and I have probably seen that video at least 30 times, and I hate watching it every time. I mean, you can even see the healthcare provider at one point, her shoe fell off. That's how hard she was hit. But something we want to note, so we never want to victim blame. What this gentleman did to the healthcare provider is never, never, never acceptable. But some things that I like to think about that maybe could have been changed prior to this situation escalating are taking the situation in a more public area. You know, it looks like maybe they're in some sort of back corner of the hospital. Someone did come and help them. But if you notice a situation is escalating, you are by yourself with the person, either get yourself out of that situation or take it to a more public area so you have more people to back you up if you need to. Avoid pointing is a big one. If anyone has ever had somebody yelling at them and pointing in their face, it's probably one of the most aggravating things, right? Both of them are pointing at each other. Both are showing a lot of aggression towards each other. Leaning in is kind of a problem as well. So again, we don't want to victim blame this individual, but leaning in kind of asserts this this authoritative force over the person. It kind of creates this power dynamic, power struggle, if you will, that probably does not help the situation. And then again, this video has no audio, but we can probably imagine that there's some raised voices on either side. There's a lot of yelling involved. So just a couple things to keep in mind to maybe try and avoid to prevent a situation from escalating further. All right, so we are going to talk a little bit about personal safety. And I know you guys have probably maybe covered this a lot, but again, I think it's super important. So refreshing it again is never a bad idea. So I'm going to talk a little bit about things that we do at the U to keep us safe specifically. I know some of them might not translate to your workspace, but just to kind of get an idea of things that you might be able to implement. So clothing and belongings, for an emergency department setting, if we ever have a patient come in expressing any like suicidal or homicidal ideations, we ask that they turn over all of their clothing and belongings. You know, that's everything down to their underwear. I have seen people hide weapons in their underwear, so Never underestimate where people can hide things. If you're in a clinic setting, obviously it's probably not going to be realistic that somebody's going to strip down in front of you, right? But just to have aware of maybe what's on them, right? Like what of their clothing can be used as a weapon. So like chunky rings or belts or like big necklaces, something like that. Proximity to the patient. So we want to be aware that every patient has a personal bubble, right? Every patient has kind of this sense of security around them. Be aware that you're not encroaching on that personal bubble, kind of give them some space. We also like to implement what's called a 6-foot reactionary gap. So if you saw a situation escalating or something like that, a 6-foot reactionary gap basically means that if the person were to lunge towards you, they'd probably, unless they're exceptionally tall, they probably would not be able to reach you if you were 6 feet away. So bringing that COVID back into our realm. And then we also like to do what's called an open stance and empty-handed stance. So kind of like what this healthcare provider is displaying right there. She is basically just a nonverbal way to say, hey, I'm here to help you. I'm not here to challenge you. And then also maintaining a 45-degree angle with those feet. So you can kind of see that she's got her feet in a little bit of a stagger stance. If that individual were to roll towards her or lunge towards her, she could easily retreat backwards as opposed to just standing flat-footed. You'd likely just fall on your bum. Always maintain line of sight with the patient. So we know that you guys are, incredibly busy in your roles. You're doing 1,000 things at once, but always kind of trying to remain aware of what the person is doing. Maybe keep an eye out for them in their periphery is really important. And then access to the exit, that's, most important end all be all. You never want to be pinned in a room where the person is between you and the exit. So always having access to that exit so you can retreat out of the situation if you need to. And then we want you guys to trust your intuition. So, we know that you guys are very smart, capable people. You've probably been in your roles for a long time. If you know that something doesn't feel right, we want to encourage you to get out and get help. All right, so we are going to talk a little bit about safety tips for site visits. So some of you might be seeing, patients, clients in not necessarily like a traditional clinic or hospital space. And we just kind of want to touch briefly on things that you can do to keep yourself safe in those situations. So staying in touch is a huge one. We always want you to touch base with your office before you're going to an appointment, when you've arrived at an appointment, when you're leaving the appointment, and when you've got back to your office, your home, wherever it is. We also want you to know where you're going. So maybe if you're going to a neighborhood, a town that you're not super familiar with, consider going a couple minutes early, kind of driving around, familiarizing yourself with the streets, just in case you needed to leave quickly in your car. And then also touching on a car, so keeping a buffer zone is really important. And what that means is if you are parking in a driveway, which I would never really encourage doing, make sure that a car can't park behind you. Just so you can have your vehicle, you can leave whenever you want. You're not enclosed if a situation were to come to that. And then establishing parameters is always a really good idea as well. So we want you to make it clear with your patient or your client that you have a schedule to keep. You'll be here to talk from this time to this time, and you will be leaving at that certain time. Just so they're kind of aware that somebody's expecting you at the next place at that certain time. Being aware of others in the home is also really important. So, we know that you might not be seeing just that person in the home. There could be many other individuals in the home. Kind of knowing what those individuals are doing at that time. Also being aware if maybe another individual is under the influence is very smart. If somebody else in the home is under the influence, we want you to get out of that situation and revisit at a different time. And then keeping a clear path to the door. So kind of like what we talked about, maintaining line of sight to the exit. Sometimes you might be meeting a person away from the door. You might have gone down like a hallway or into a living space or a couch area, common area. Just having an idea of how to get out of that situation, which turns you made in that building is very, very important. And then guarding your privacy. So, we talk about social media often. These people are your clients, your patients. It is not a good idea to friend request them on Facebook, no matter what kind of rapport you've built with them. It's just a good rule of thumb to not share social media with your clients or your patients. And then guarding your privacy as well. So that even comes down to like, if you were coming to a home visit, maybe you have your kid's high school bumper sticker on your car, or you have a picture of your family as your phone background. These are things that are private to you and could give people some information that maybe they would choose to do something not very good with. So just keep in mind if you have those things. All right, so we are going to talk just very briefly on guns and other weapons. I know that guns are a hot topic in today's day and age. What we want to encourage you to do is to know your facility's firearm policy. At the University of Utah Health, we don't allow guns on our property at all. If someone were to come into our emergency department with a firearm, we'd either ask that they return that to their car, or if they maybe got dropped off by an ambulance or something like that, we could actually take the gun, put it in our gun safe, and keep it for the extent of their visit. Local police departments will also pick up guns and hold on to them if maybe you didn't have a security on site. I know sometimes patients or clients are a little bit weary about letting their firearms go, but ultimately, if that's your policy in place, just set firm, hard guidelines with those individuals. And then along with guns, we also want you to be aware of maybe what could be used as what we call like non-traditional weapons in an exam room. So that could be anything from like a stapler to a trash can to a little bedside table stand. Those could easily hurt you. Stanley water bottles are one that are as heavy as a brick. So if somebody had one of those, they could probably wield it as a pretty decent weapon. So just be aware of what they have in the room. What might you want to move away from the person if they start escalating?
Yeah, we know that in rural communities, we've heard giving this presentation with a lot of different people in the region that gun culture can be a little different in rural communities. And sometimes that means that your organization's policy may allow firearms to be in the facility. So being aware of that and being appropriately prepared is really important. We're going to talk a little bit about communication. So there's a famous study by Dr. Morabian from 1976 that I'm sure you've heard, and it goes through about how much of your communication is actually verbal versus nonverbal. So we know that 55% of the message that you're sending is nonverbal. So that means appearance, body movement, posture. As we saw in the video earlier in the hallway, the hand pointing, the leaning over and standing over, she was standing and the patient was sitting, that type of stuff, that is what can escalate a situation because communication through body language is really important. So eye contact, facial expressions, those communicate some sort of message, whether the message is that you're safe, you're unsafe, you're nervous, all of those things. Paraverbal and touch too. Paraverbal communication is about the tone of voice, the pace in which you're speaking, the pitch, the volume. Obviously, if someone is speaking really rapidly, really loud, that can indicate that maybe they have been triggered and are escalating into a crisis state. So those types of things are something to watch for both in your clients or patients as well as yourself. You're wanting to show that you're a safe space, but also observe where they are in the crisis cycle. And then only 7% of what you're doing is your words of the communication that people receive. So just be aware that you know, what you're doing with your body and your voice is really going to communicate a lot, and what other people are doing, pay attention to that. So part of workplace violence sometimes includes sexual harassment or other misconduct. It's not always physical violence or attacks, but a lot of times can be verbal or sexual. So we know that this can obviously be speaking derogatory terms, swearing, or even in a sexual way, if people are commenting on the way you look, or asking a nurse out. A common phrase that we talk about is saying, "I'm here to take care of you. I'm not interested in another relationship." So emphasizing that boundary and that parameter early on, that you are there to take care of them, you care about them, but you are not interested in any sort of private relationship, sexual or otherwise. So some sexual harassment or other misconduct could be nonverbal or visual, meaning They could, do a hand gesture that's unacceptable, that could be threatening. There could be visual. Oftentimes in healthcare settings, that could look like showing people private parts of the body that they don't want to see. And establishing a parameter with that, again, is very important, saying, excuse me, I need you to cover up immediately. Those types of things, setting a firm boundary is important. And then, of course, physical touch that's unwanted should definitely immediately mean you need to leave the scene and report it. And then there's psychological. This could be some sort of manipulation. Oftentimes in healthcare settings, it's staff splitting. So using, saying, well, this nurse told me this, and kind of using staff against each other. And I saw that obviously as an educator. That, well, so-and-so said this, or this rule is okay in that classroom, and just not allowing that kind of psychological game to change your boundary. And then obviously this can happen with patients or coworkers. The idea for escalation and de-escalation is that it's happening in a workplace and not necessarily just from clients. So just talking a little bit about factors that influence behavior. Oftentimes people come into a setting and we don't know the whole story of their lives, their background, what's going on. And that really will influence how they're behaving, particularly in healthcare settings, which trigger a lot of people. So if there's any past trauma, that can be triggered. And once someone's escalated, they may not even know it, but it can trigger the limbic system and that fight, flight, flee or freeze or fawn response. So you may not know, like it might not be in their medical history notes that they had some sort of trauma, or obviously we don't know in every setting what trauma someone's had. Finances, going into certain situations, a mental health provider knowing this is going to cost me $150 out of pocket, where someone can't put food on the table, something like that, that definitely will influence their behavior, maybe more nervous, agitated, or angry. And then cognitive abilities. Obviously, this has to do with people's cognitive neurodiversity. Maybe someone's neurodiverse, the way they talk and act and their mannerisms will be different. Or it could be just their cognitive abilities, whether they have signs of dementia or something like that. Physical abilities, for sure, if someone's really ill, that will affect their mood or behavior. If they have a chronic illness or an injury, and then, time of day, maybe they're more tired, time of the appointment, maybe they're in a rush. Oftentimes they're in waiting rooms, they don't like that. And then substance use, if they show signs of impairment, as Molly mentioned, that's really important to note in healthcare settings. Obviously, that doesn't necessarily mean you leave the setting, but in some settings like a home visit, you would definitely need to leave if there's impairment, because that increases the likelihood by, exponentially of some sort of aggressive or assaultive behavior. And then the last one to touch on is culture. And there are a lot more that probably influence people's behavior, but culture and, their cultural background and understanding definitely is part of it. So I'm going to switch really quickly and we're going to watch a 2-minute video. And that's about cultural competency and humility. So let me just get that really quickly.
Cultural competency and cultural humility. You may have heard these terms before, possibly in the context of healthcare settings, and not quite understood what they meant. Let's go over what these terms mean and how they apply to everyday life. To be culturally competent, is to learn about other cultures, control your biases, and adapt your behaviors and communication style considering the background of people around you. The goal of cultural competency is effective and informed interaction across various cultures. At face value, cultural competency sounds ideal, but it may actually lead us to rely on generalizations about certain groups rather than recognizing the uniqueness of each individual. We also have to ask ourselves, is it realistic or even possible for people to learn everything about other cultures and become completely bias-free? That's where cultural humility comes in. To be culturally humble is to be aware of social power imbalances, respect other people's values and beliefs, and continuously reflect on your own biases. With cultural humility, there's no expectation that you memorize everything there is to know about other groups. Instead, it's a lifelong process of asking yourself how your own biases might impact the way you treat and understand others, alongside work to minimize that impact. Cultural competency is a goal, while cultural humility is a mindset. Let's go over a few ways to practice cultural humility in our daily lives. Recognize that no culture is superior to another. Become comfortable with reflecting on and acknowledging mistakes you've made. Be honest when you're not sure about something. Learn about other cultures with the awareness that you'll never reach perfect understanding. Ask the people in your life if you can have open discussions and hold each other accountable during your learning journey. The great thing about cultural humility is that it acknowledges that no one can get it right all the time. In fact, a key component of cultural humility is being open about what we haven't learned yet. Although it can feel really uncomfortable to admit when we're wrong or don't know something, that vulnerability leaves room for us to continuously learn, grow, and promote equity and inclusion in our communities.
Okay, any thoughts on that? You can enter them in the chat.
I kind of like Annie how they talked about how it's like a lifelong thing. You're not ever gonna hit a peak of cultural competency. It's a continuation of learning about different cultures and being willing to open your mind and accept that you don't know anything. So,
And initially, when we think about cultural competency, we may not immediately think, oh, that has to do with escalation or de-escalation or crisis situations. But we live in a really diverse world with diverse backgrounds and traditions. And oftentimes cultural misunderstandings, as we've seen throughout the world, can lead to much bigger escalations that can lead to violence. So having cultural competency and understanding and humility as you approach a situation can look even physical, as Molly said, with your hands up, open. If someone has past trauma or misunderstanding, maybe in their culture, if you have your hands behind your back, you can't trust that person. You know, it's a lot of things like that through your body language, through your tone, through asking questions and being understanding can already de-escalate a situation at the very beginning.
awesome. Before we keep moving on, does anyone have any questions? I know this is kind of a lot of information, so feel free to speak up or write them in the chat if you have any thoughts, questions. I see some great thoughts in the chat, so I appreciate you all throwing those in there as well. All right, well, we will keep on moving. So next we want to talk about a concept called social triage. So when someone comes into the hospital, clinic setting, something like that, we know that they're probably going to be seen for a medical reason. But we also want to think about maybe what their social needs might be as well. So when we think about those social needs, we are going back to Maslow's hierarchy of needs. I'm sure that everyone has probably seen this before. This might be giving you some PTSD from your freshman psych class in college, but I promise it won't be too painful. Just to review, if someone hasn't seen it though, so Maslow's hierarchy of needs is a 5-tiered system, and it basically talks about how needs lower on the pyramid need to be met before needs higher on the pyramid can be achieved. So you see you've got that self-actualization all the way at the top there. Way down at the bottom is where we see our physiological needs. So we're talking food, we're talking shelter, we're talking clothing, right? if those needs aren't met for individuals, they can't even feel safe. So thinking about that, I know a lot of times in the emergency department, we saw patients that were living at this physiological needs level. They had food insecurity. They were in between housing. They didn't have the proper clothes for the weather that was happening outside. So by addressing, maybe one or two of those needs, we could actually get a lot further in the appointment, a lot further in the interaction. The VA has actually done a study on this showing that, oh yeah, sorry, I was watching the chat. I'll have Annie go back to that one really quick. But the VA has done a study basically talking about how meeting just one physiological need for patients can reduce the risk of violence by 50%, and meeting two of those needs can actually reduce the risk of violence by 70%, which is huge.
Yeah, that statistic was that 70% of all workplace assaults in the US are in healthcare settings, with 47% of physicians reporting that they have been physically assaulted. And then in 2022, 2 nurses are assaulted per hour, according to that study.
And I think that 2022 study was done by Press Ganey as well, if you wanted to look that one up. Yeah, of course. So we're going to talk about the crisis cycle. So the crisis cycle is essentially just a pattern of behaviors that people go through when they're in crisis. Something to note, so we actually need to update this graphic. A lot of times this cycle is not this beautiful linear wave where people kind of experience one emotion, they go to the next, seemingly they go to the next, they're done. A lot of times it's almost like a wheel, right? So they'll go from crisis to back to their trigger, to recovery, back to their baseline, maybe back to crisis. So just thinking about that when we're talking about this. But just to briefly cover a couple of stages of this. So the first stage, stage 0, if you will, is your baseline or in control. So this is you and I right now, we're having a calm discussion. Hopefully we are not boring you to death. Nobody seems to be getting antsy, triggered, anything like that. Stage 1 is going to be your trigger phase. So a lot of times this is when the patient will be taken out of their baseline state. You might notice a slight change in behavior at this point, maybe like, clenching of the jaw, tensing of their shoulders, making a fist, something like that. If you notice this, at this point, you should still take a supportive and calm approach to care. So, remember to remain positive, try providing those simple and direct answers. You can always try redirecting the person or distracting them, and continuing to set those clear boundaries with the individual as well. So stage 2 is your escalation phase. So at this point, the individual might lose rationality. Maybe they'll become anxious. Maybe they'll start pacing the room or expressing some rapid speech. They might become aggressive, maybe yelling, punching walls, stuff like that. This is a really good time to employ some de-escalation techniques to hopefully prevent the person from getting into that crisis stage. And we'll talk about a couple more of those in upcoming slides. And then, so the crisis stage, which is the peak of the crisis cycle. So this is peak escalation. This is when the person starts behaving in a way that may harm themselves or others. They could be expressing that assaultive behavior, verbal aggression, threats towards you, your coworkers, anyone else in the situation. This is really when we want to, maintain our safety. And again, we'll talk about that in the next slide. The calming down phase, or stage 4. So this is kind of what we call like our tension reduction phase. A lot of times this takes almost up to 90 minutes. So quite a bit of time. At this point, we really want you to observe from a distance, try and limit words with the person, try to remain positive if you can. And then the last stage, so the recovery phase. A lot of times in this phase, patients will express remorse for what they've done. I always try and remember, if someone comes in, they're threatening to hit me, they're punching walls, they're, doing all sorts of inappropriate behavior. They get to this recovery phase and they say, I'm sorry for what I've done. Something I really, really try to remember not to do is say, it's okay. Right? Say it's okay, because us as humans is we just want to, cover it up, make it better, just sweep it under the rug. Saying it's okay really validates the behavior they just expressed. And it's probably gonna, have them do it again in the future. So instead of saying it's okay, I really want you to encourage you to be like, you know, thank you so much for your apology, but in the future, if you feel yourself getting angry, please take a couple minutes to yourself so we can prevent a situation like this from happening. It's a really great time to negotiate future behavior at this point. All right, so some priorities when responding to crisis. So top priority is maintaining safety. This is maintaining safety for yourself, maintaining safety for your coworkers, and maintaining safety for the patient or client as well. The first thing we want you to do if you notice a situation is escalating is we want you to stop and assess that situation. So, we already spoke about environmental awareness, situational awareness. We want you to make sure that you've got that easy access to the exit should you need it. Keep in mind what's around you, maybe a chair, those big Stanley water bottles. What could that person use to potentially harm you? Continue to try and do that neutral stance with your open hands, 45-degree angle of your feet. And then try to only have one person verbally interact with the person. Multiple people yelling at the person or raising their voice can be confusing and likely worsen a situation. So really try your best to only have one person verbally interact with the escalating individual. Remaining professional kind of goes without saying. We try and remember that the person is not upset with you, they're upset with the situation, right? So the goal here is to be, respectful of the patient's feelings, try and detach from your own attitudes and remain those professional boundaries. We like to say, check yourself, try not to impose any feelings that you might have towards this person. Say maybe you have a family member that struggles with addiction and you have a patient that has addiction problems. Try not to impose any feelings that you might have, previously towards that patient. And then tap out. So, we've all seen that person that maybe is kind of starting to become part of the problem with the patient. If you notice that yourself or your coworker is doing this, we encourage you to tap out. There's no shame in leaving a situation if you feel like you're not getting anywhere with the person. Sometimes it's just you two are not meshing well and maybe somebody else can get through to them. So tap out if you feel like you need to. All right, so we are going to talk a little bit about some interventions for an escalating situation. So active listening is always a great intervention to do. Annie and I took a class recently, and one of our security officers basically was like, sometimes we just sit there and let the person yell at us, and that's what they need. It's not appropriate for a person to yell at you ever, but sometimes that's what they need, and sometimes that's the easiest thing to just do, to just sit and listen to them. But two of the main components that make up active listening are undivided attention and empathy. So we always try and maintain eye contact with people. A lot of times I'm guilty of this. When I'm taking care of a patient, I might be grabbing labs, I might be hooking them up to their monitor. I'm talking to them, but I'm not making eye contact with them. Giving them, just brief eye contact kind of gives like a meaningful connection of, hey, I'm listening to you. Hey, I'm here to take care of you. It can go a long way. Responding appropriately. So I know I am a big people pleaser. A lot of times people would say, when's my CT scan? And the real answer is, I don't know, probably in, several hours. That answer is probably not going to sit well with people. It's probably going to trigger them. So instead, I would say, I'm not sure, but let me go out, call the CT scan right now and see if I can get a better answer for you. Just trying to be, as honest as you can, as transparent as you can to hopefully avoid escalating situations. And then we kind of talked about this already, but multitasking with a purpose. So it's okay if you're grabbing those labs, if you're hooking your patient up to a vital sign while you're, while you're speaking to them, while you're orienting them to the room, but just letting them know like, hey, I'm listening to you. I'm going to write down everything you're saying, but I just need to get you on this monitor first. And then empathy. So I'm sure we're all pretty familiar with empathy. For me, it's kind of a complicated concept, but in short, it's when you understand the feelings of another, but you don't necessarily share them yourself, right? We used to show a video by Brene Brown talking about empathy, and we decided to cut it out for time's sake, but it's a great video, just a quick little thing on what empathy really means and how we can use it when interacting with people. But some really great tools that fall under empathy are restating and paraphrasing. So maybe you have a person that's really upset with you. You could restate why they're upset. So let me see if I understand you correctly. You're upset because the doctor hasn't been in to see you yet. Pausing and reflecting is also really beneficial as well. So you could say, that must be really hard for you. Thank you so much for sharing with me. Open-ended questions, you could say, I'm really sorry the doctor hasn't been in to see you yet. What can I do to make you feel more comfortable at this moment? Just to kind of ease some of that tension, and put yourself in their shoes. All right, so if we are past the point of active listening, sometimes we need to use verbal interventions. A lot of times this is kind of at that peak crisis state. If the person isn't listening, or if the person is not really calming down after active listening, then a lot of times we have to verbally interact with them. So redirecting is a great tool that you'll want to use. A lot of times people will start challenging your authority. A lot of times you want to try and ignore these challenges and bring your focus back to the problem at hand. So, you know, maybe if someone really wants to go out to smoke in your facility has a no smoking policy and they just start going that off, you can say, listen, I need you to stop yelling at me. We need to continue your appointment, and then you can go smoke after. Limit setting is very important as well. Again, we want to set those hard boundaries with patients. So you can say, you know, if you continue to yell at me, we'll have to cancel this appointment and reschedule. And then offering choices is great as well. Someone taught me the term a weighted choice. It's a lot of times what we use with kids. So it's essentially a choice within a choice. And basically you can say like, you can either stop yelling or we can cancel your appointment. You can't say like, would you like to stop yelling? Because likely the answer is going to be, no, I would not like to stop yelling.
Yeah, I am a mother of 2 young boys, and I know very well the importance of weighted choices. Would you like broccoli or carrots? So just reflecting a little bit about what we've been talking about, just thinking of someone who's coming in, for example, to an emergency room or to your office. Imagine that they're coming in and they have maybe some past trauma. Maybe they're an immigrant and in their childhood were a victim of violence. Maybe because they're an immigrant, they don't have a steady job. They may not have financial security. And then maybe in the hallway, someone looks at them with a glare or says something that might be derogatory to offend that person. And then here you are, and you are the next person interacting with them. They already are bringing in all of this baggage and may already be triggered. You may notice as they come in, they're tense, their hands, they're tight. Maybe they're speaking really brief, short answers, maybe looking nervous, looking around. You can already think, okay, this person is triggered. That's when you immediately begin the active listening phase, your cultural competency, maybe saying, tell me about yourself, calling a translator if necessary, all of those things. But then if things continue to escalate, as Molly said, that's when you may need to consider asking for help. And that can come in a variety of ways. For some clinics or workplaces, you may just have a cell phone or a clinic phone or some phone to call in like an additional person, a coworker to come in to deal with the situation. We would encourage to do that when it's escalation, not crisis, because when it's already escalating, you need to have time for the other people to come. At the U, there's a team called the BERT team, where multiple people, if a certain button is called or a code is called, multiple people automatically will show up at the room and then do a little huddle and discuss the situation with the initial contact. But there are also options of emergency buttons. So a lot of clinics and healthcare settings have emergency buttons or panic buttons under a desk, perhaps near a front desk or by the charge nurse. So knowing in your situation, does your facility or hospital have emergency buttons? If not, what could you use as an emergency button? So if you don't have one, maybe you need your smartwatch to have a speed dial of the front office that you can press one button and it will speed dial and you can make sure someone's ready to come. Maybe you need to call a code. There was actually a facility that we talked to who was considering getting all their employees whistles, which seemed a little extreme to us, but could be an option, you know, if you really want to just have something physical on to alert others. So there are a lot of easy install, affordable options out there, but this is something that a workplace can do to make it accessible for someone, whether they're in an escalating or a crisis situation. So like I said, I would like you to kind of think about what your personal panic button could be, whether it's your phone, or a code or another thing that your workplace has. So when incidents do occur, as we've talked about, you're addressing the behavior, telling, not asking. So saying, instead of saying, will you please sit down, say, I need you to sit down. And when necessary, leave the room. As I mentioned at the U, we have what's called a BERT team, and what that is typically a member of security, and then maybe a charge nurse or a supervisor type of person, and they will come and they are trained to deal with crisis situations. So they're well versed. So if I were in an escalated situation and I didn't know what to do next, definitely call the BERT team. I would meet them in the hall and we discuss next steps. If I'm not comfortable communicating with the patient anymore, I would say one of you needs to be the mouthpiece. As we mentioned, it's best for one person. If there's a group of people addressing the patient or client, that one person is this one who's speaking and setting boundaries. If it's multiple people, it can cause a different dynamic and make things worse. So you're alerting security, your coworkers, you huddle and you discuss next steps. And then afterward, definitely report the incident and seek and offer support. So if it was traumatic for you, discussing that with your supervisor, and making sure that the incident is reported in whatever system you use. So the system that the U uses is EPIC or RL6, which it means if something happens, you have to document it for internal, for HR purposes, but also for the purpose that if there is a patient that has a behavior that's maybe aggressive or sexual assault or whatever, it needs to be in the system for future coworkers or future caretakers to know. Because if they don't know that this has happened in the past, a lot of people, repeat the behavior, repeat offenders, and those notes of exactly what happened are really crucial for keeping others safe, not just yourself. So if you are in the middle of a crisis situation, the Utah crisis line, this number is here, 998. Obviously, if someone is considering hurting themselves, it's a suicide hotline. And after a crisis situation or an escalated situation or just a hard day of work, a lot of people who are in the healthcare field or the education field get burnt out and worn down. The Utah Warm Line is available 8 a.m. to 11 p.m. and it's free of cost. You can call and just have someone to talk to. So as I mentioned, reporting is really important. By reporting hostile clients, you create protection for yourself and your coworkers. And so we encourage you to know what forms, what documentation, what procedure needs to happen after an assault or a crisis situation. So you also take part in creating policies at your job. If multiple crisis situations happen, a supervisor may escalate it to a director who may escalate it, to an executive who then can make a new policy to help protect the workers in your workplace. And then also there's laws that are in place in the state of Utah as well as nationally that have been enacted due to seeing the statistics of workplace violence. So in Utah in April of 2021, they passed this law to protect healthcare workers from assault. And then in 2016, there was one that was states that assault against a healthcare worker is a Class A misdemeanor or third-degree felony if there's substantial bodily injury. So that if these things are happening, there are going to be consequences, and so you should be protected. Again, it's important to protect yourself and be prepared for an escalation or a crisis situation. And then there are
Annie, really
national.
quick, I'm sorry to interrupt.
Yeah.
Julian gave a great comment in the chat. The crisis line number is 988, not 998. I apologize. We have
sorry.
no, we have that as a typo in our PowerPoint. So
Yeah,
it is
I know.
988.
I just realized that.
Sabrina had a great question. The warm line used to be for SLC County clients. I believe it just extends to Salt Lake County. I will double check on that for you and get back to Carissa on that. So she can let you all know, but I was under the impression it was just for Salt Lake County.
I was just
Okay.
looking it up. It says that it is a free statewide hotline that provides support to Utah residents who are not in crisis but are looking for connection with peers. And it's
Yeah,
available
I think
8
it's
to 11.
statewide.
Yeah, 8 to 11, 7 days a week.
Yeah, I'm pretty sure it's statewide. Obviously, in a crisis situation, you're going to be needing to press an emergency button, call the police, all of those other things. But in a lot of settings, a warm line could be helpful for yourself or for a client.
Yeah, it just gives them connection with peers. It says that they connect them with someone that has dealt with similar and can give them help and support.
Yeah. Great.
They said it's also available, 365 days a year. Well, as long as it's 8 to 11, 7 days a week. So, and it's free.
Yep. Okay. Sorry about that. So identifying what can be used as an emergency button. As I said, emergency buttons don't necessarily have to be a physical button, but some sort of plan you have in place where it's like, the situation is escalating. I need help. What is my button to push? Is it my phone? Is it an actual button? What is it? Learn how to access and utilize reporting systems in case an incident does occur. And even before an appointment with a student or any client, look for notes in the system. Because you want to know if 2 weeks ago they came in and assaulted a nurse. You want to know that so that when the appointment happens, you have someone else on hand, or you maybe have security in the hallway just in case that happens. You can be way better prepared if there are notes and you're up to speed on the patient or client. And then familiarize yourself with the current emergency response plan. So this means every workplace has a different plan. Hopefully yours has some sort of plan. Oftentimes people need theirs to be updated or to maybe be expanded to include different categories of crisis. Sometimes there are only limited categories that they cover. So make sure you understand what the emergency response plan is and what codes you need to trigger in case a situation happens. And then last, we have some resources through the U, through our department. Besides this de-escalation course, we have a lot of opportunities for education, whether it's a clinical education, more administrative, or psychological training. So feel free to join any of our events. Any questions or comments?
Thank you, Annie and Molly. That was great. That went right along with all the other things we've been discussing, reinforcing some of those and adding some new things. So thank you very much. I learned some new things from it. A great presentation. Will some of the slides be available to upload with this recording?
Yeah, absolutely. We can share our slides. I think we maybe edited a little bit since the last slides that we sent you, Carissa, so we can just send you an updated version and you're more than welcome to share them.
Perfect. We'll just upload like a PDF of it.
Perfect.
Thank you. So that people can access those resources and references. So Thank you so much. What a great ending to this whole series. And thank you for those that have come and attended and supported it. So I really appreciate it. And hopefully it helps. But thank you very much, Molly and Annie. That was excellent. So I forgot to have my glasses on.
Thanks for having us.
Thanks.
Yeah, thank you.